Hey everyone, and welcome to this explainer. Okay, let's just dive right into it. Have you ever looked at a super complex diagram of the human nervous system and just felt, totally overwhelmed? Well, today, we're going to change that. We're demystifying two specific and honestly notoriously tricky nerve injuries, ERB'S palsy and KLUMPKE'S palsy. And the way we're going to do it is by treating the upper body's wiring literally just like an electrical fuse box in your house. Once you grasp the basic circuitry we're showing today, you'll see exactly how a single blown fuse can completely rewire how an arm moves. Let's get into it. So here's our roadmap for today. First up, we'll map out the brachial plexus network. Then we hit ERB'S palsy, the upper injury, followed by KLUMPKE'S palsy, the lower injury. After that, we'll put the two side by side to compare and wrap up with your key clinical takeaways. All right, Parts 1, the brachial plexus network. So the brachial plexus is essentially your upper body's electrical fuse box. It's this incredibly dense network of nerve roots that starts right at the neck. Specifically, we're talking about cervical nerves, C5, C6, C7, C8, and the first thoracic nerve, T1. This whole bundle travels down to power all the sensation and motor function of your upper limb. Now think about your house for a second. If the upstairs fuse blows, well, the upstairs lights go out, right? But the basement is totally fine. And if the basement fuse blows, the upstairs stays perfectly illuminated. The brachial plexus works the exact same way. A blown fuse at the top of this network is going to cause drastically different physical deformities than a blown fuse at the bottom. Moving on to Part 2, ERB'S palsy, which is our upper injury. So what actually happens when those upper roots tear? It's really a mechanical question. These nerves don't just randomly fail. They're subjected to really intense physical forces. So how does the top of our fuse box actually end up getting damaged? The absolute crucial word here is traction, specifically yanking or pulling the head away from the shoulder. The causes of ERB'S palsy all revolve around an excessive increase in the angle between the head and the shoulder. This basically stretches those upper nerve roots, C5 and C6, way past their breaking point. Just imagine falling from a horse and landing super hard on your shoulder while your head violently snaps the other way. Or, in a medical setting, traction of an infant's arm and shoulder during a really difficult birth. These intense mechanical forces literally stretch and tear the top of our fuse box. Now, what's really fascinating here is the specific location of the damage and the result. If you look at this anatomical diagram, you'll see ERB'S point. This is the exact junction where the C5 and C6 roots meet. When the trauma happens right here, it immediately cuts power to some very specific muscles: the deltoid, the supraspinatus, the infraspinatus, the biceps brachii, and the brachioradialis. And here's the kicker. Because these specific muscles are suddenly dead in the water, the muscles that are not paralyzed take over. They essentially overpower the dead ones, pulling the arm into a highly specific, unmistakable posture. Medical professionals often call this the policeman's tip or the waiter's tip hand. It's the absolute visual hallmark of ERB'S palsy. Because the muscles that normally lift and rotate the arm outward are completely knocked out, the arm just hangs limp by the side, pulled tight against the body, which is what we mean by adducted. It's medially rotated inward, the forearm is extended straight, and the wrist is pronated. It literally looks exactly like someone's subtly asking for a tip behind their back. Anchoring all that clinical jargon to this everyday visual of a waiter's tip, it makes it incredibly easy to remember. All right, let's shift gears to Part 3, KLUMPKE'S palsy, our lower injury. So if ERB'S palsy is caused by aggressively pushing the shoulder down and the head up, KLUMPKE'S is the opposite. It's caused by yanking the arm straight up. In medical terms, this is called hyperabduction. The classic causes here include desperately grabbing a tree branch to stop a fall, having your arm pulled upward into industrial machinery, or an extended arm in a breech delivery. Basically, we're talking about high-energy upward pulling events that absolutely rip the lower roots of our fuse box, specifically C8 and T1. And because we blew the bottom fuse instead of the top, the physical result is completely different. With C8 and T1 damaged, power gets cut to the flexors of the wrist and fingers, and crucially, all those delicate, intrinsic, fine motor muscles of the hand. This creates a starkly different but equally recognizable visual outcome known as the claw hand. The upper arm and forearm might be totally fine, but the hand itself becomes severely curled and paralyzed. But wait, there is a totally fascinating neurological twist when it comes to KLUMPKE'S. Because that T1 nerve root is involved, we don't just see muscular issues. We actually see autonomic nerve signs. The T1 root carries sympathetic fibers for the head and neck. So if you rip T1, you sever the sympathetic power to the face. This results in Horner's syndrome, What does that look like? It means a drooping eyelid, which is partial ptosis, a constricted pupil, or miosis, a total lack of sweating on that side of the face, called anhidrosis, and even a sunken eye, or an ophthalmos. This is a massive clinical clue. If you see a claw hand plus a drooping eyelid, you know exactly which fuse is blown. Let's bring it all together in part 4, comparing the two palsies. Ultimately, it all boils down to upper versus lower. Upper roots C5 and C6 give you ERB'S palsy, lower roots C8 and T1 give you KLUMPKE'S palsy. It's really that simple. Top of the fuse box versus the bottom of the fuse box. Let's walk through this ultimate cheat sheet together. Just look at the muscles that are paralyzed. ERB'S takes out the heavy lifters, the big movers of the shoulder and arm, like the deltoid, biceps, and brachialis. KLUMPKE'S, on the other hand, takes out the intricate micro-movers, all those intrinsic muscles of the hand. And because of that, the resulting limb positions are perfectly opposed. ERB'S gives you that classic waiter's tip handing at the side, while KLUMPKE'S gives you that tightly curled, paralyzed claw hand at the very end of the limb. And we definitely can't forget about sensation and those autonomic signs. With ERB'S, sensory loss happens along the outer aspect of the arm, which makes sense, that's C5 and C6 territory. But with KLUMPKE'S, the numbness is along the medial border, the inside edge of the forearm and hand. And as we just covered, autonomic signs like Horner's syndrome, totally absent in ERB'S, but remarkably, undeniably present in KLUMPKE'S due to that T1 involvement. I mean, this kind of stark contrast is literally a diagnostician's dream. Finally, part 5 are key clinical takeaways. If you take absolutely anything away from this explainer, let it be this structured summary right here. Top fuse blown equals ERB'S, hitting nerves C5 and C6. Bottom fuse blown equals KLUMPKE'S, hitting C8 and T1. Your quick visual markers are the waiter's tip hanging by the waist for ERB'S and the tightly wound claw hand for KLUMPKE'S. And for that expert-level diagnostic bonus, if you spot Horner's syndrome, you know immediately that the T1 nerve root is involved, pointing you straight to a lower plexus injury. We have covered a lot of ground today, right? We've basically mapped complex anatomical damage to highly visible, everyday physical signs. So I'll leave you with this. The next time you see a specific arm deformity, whether it's in a textbook, in a clinic, or honestly, even in a movie, will you be able to trace that visual clue backwards to the exact blown fuse in the cervical spine? By looking at the human body structurally like we did today, you now have the tools to do exactly that. Keep exploring and keep questioning how the wiring connects.